Hello, welcome again. Dr. Anthony Gonzalez here for Miami Community Health. We're here again to bring you another important health topic for you to learn about today. And this topic today is a little bit different because obviously we all have had families and friends who have had conditions related to the blood. And we are going to talk today about blood conditions. We're going to talk about hematological conditions and different conditions that people can have of their blood. And of course, what better to bring you an expert that we have in a community, Dr. George Nahas. Dr. George Nahas is here from Miami Cancer Institute. We know Baptist Health has a large cancer center that they have created and are developing, and George deals with all these hematological blood conditions. So, George, welcome.
Thank you. Well, I appreciate you giving me the opportunity to talk about this topic.
Well, my pleasure. My pleasure. So first, tell us who you are. What do you do?
Okay. So I've been at Miami Cancer Institute for about 3 years now, a little over 2 years, between 2 and 3 years. I am one of the bone marrow transplant physicians there. And I also was part of some cellular therapy trials as well. And broadly speaking, malignant hematologist. So kind of a jack of all trades, do a lot of different things there, specialization in bone marrow transplant.
So what got you interested into this? Because, you know, obviously as a doctor, we go to medical school and you hear these specialties, and that type of specialty never interested me. What got you interested in that area?
Yeah. So, I actually, during my medical school, I was involved in a breast cancer stem cell research lab. It's kind of a mouthful, but it kind of really ingrained me into the nitty gritty molecular and cellular aspects of medicine. So with that being said, I ended up, going in that lab, and I got hooked up with a bone marrow transplant physician. Again, this was when I was a third or fourth year medical student. Bone marrow transplant physician when I was in New Jersey. And since that time, it's and I've heard this metaphor. It's kind of like almost like using science fiction, whereas you are, and I think we're going to get into this a little bit later about how a transplant actually worked, where you're really using, stem cell therapy and pretty much the most like bench to bedside kind of aspect of medicine with regards to completing a bone marrow transplant. So that really intrigued me pretty intensely when I was a medical student, and that theme kind of stuck with me throughout my residency. And then I finally went to fellowship, and then lastly I did a second fellowship actually, and now I'm attending in this particular field.
Wow, great. Yeah, no doubt that this is a very complex field, and it's an evolving field. We've seen that through the years. It's an area where there's a lot of research and a lot of new findings and discoveries. So let's talk. We're going to try to cover today a couple important topics that are areas that you specialize in, because we always want to hear from the specialists. And the first one we're going to talk about is multiple myeloma. And so, what is multiple myeloma? Explain to us what that is.
Yeah. So basically, our bone marrow is a factory for our platelets, which basically they make sure we don't bleed. So they clot different things. It's factory for our red blood cells as well, which essentially carries oxygen through different tissues of our body. And finally, it's the factory for our white cells, which is our immune system. So our immune system is composed of many different types of white cells. In particular, there are these particular cells called plasma cells, and they create antibodies. And we hear, especially in this day and age, we hear a lot about antibodies and they're good or what have you. And but if you have to have a kind of like an orchestra of different antibodies that do different things, so you can handle different types of infections. In multiple myeloma, you can have one cell creating one type of antibody ad nauseum, meaning there's so many antibodies of the same antibody. You don't want that. When you create so many antibodies, they can cause problems. They can hurt the bones. For lack of a better description, they kind of eat up the bones a little bit to make the bones weaker. They can hurt the kidneys, and they can hurt the bone marrow itself. And again, the bone marrow creates a normal immune system, a normal red cell production, which carries your oxygen, and normal platelet counts. So those counts can drop. So that is essentially what multiple myeloma is, and it's a blood cancer. And blood goes everywhere in your body, so you can see how it affects multiple different aspects of your body, like I just said.
Wow. And so is there a way to prevent this? Is there a way that a viewer can say, wow, I don't want this condition. I don't want this condition.
Yeah.
How do I prevent from getting that?
I get this question all the time, and it's a great question. I especially get it from patients who are newly diagnosed, and they say, oh my gosh, how did I, how could I have prevented this? What can I tell my family members, my sons or my daughters? And again, this is a type of cancer of older patients as well. And the best way to prevent it per se is to is to really just kind of just be in tune with your body, go to your doctor on a regular basis. There's no screening test, right? We go to get a colonoscopy to make sure we don't have colon cancer. We get a mammography to make sure we don't have breast cancer. But there's nothing really, like there's no test that you can do once a year or every other year, or so to speak, to test for multiple myeloma. So there's nothing you can really do to prevent it. If you have a good primary care doctor, which I assume a lot of people do, they will be able to kind of interpret your basic blood work, and they can kind of see some protein levels and some different laboratory work they find a little bit off, and then lots of times they will then say, this looks weird, maybe myeloma, let me send it over to Dr. Nahas and let him take a peek at the labs.
So we can't prevent it. Now let's talk about treatment. So what happens? You get that patient, they get abnormal protein levels, abnormal white cells on their blood count, and I get my blood drawn every year by my primary doc. They go to you. So what is the treatment for this?
Multiple myeloma is a huge spectrum of what it actually is. So there's basically three types of multiple myeloma. There's something called monoclonal gammopathy of undetermined significance. It means that the multiple myeloma burden is so low, you don't treat it, you just watch it. There's a middle tier called smoldering myeloma, where you kind of watch it, but you watch it much more carefully. And some patients sometimes warrant treatment. And then finally, there's multiple myeloma that warrants treatment. And the patients who warrant treatment, multiple myeloma is kind of moving away from chemotherapy. And I should say not moving away, but it's kind of moved away from chemotherapy. The traditional therapy is a combination of a couple. You're going to get either 2 or 3 different medications. Sometimes in some circumstances 4 medications. Some of it kind of potentiates the immune system. Some of the drugs are steroids. Some of the drugs are, these chemicals that kind of kill the multiple myeloma cells from the inside. But traditionally, like at this point, we don't really use rote chemotherapy to treat myeloma at this time. It's got good outcomes. And if you are young enough and healthy enough, you then, after that original therapy, you will then be eligible, or could be eligible, or be considered for a stem cell transplant. Stem cell and bone marrow transplant can use interchangeably. And for multiple myeloma, you get your own stem cells back. So what happens is that you get this is the only time, and I know I said no chemotherapy, but it's the only time you get chemotherapy for a stem cell transplant. You get 1 day of chemotherapy, one-time dose. It knocks out everything in it knocks out as many of the plasma cells as possible, those bone marrow cells, those bad myeloma cells that are hiding in your bone marrow. As collateral damage, it knocks out your own stem cells. So the way you kind of get around that is before we give that chemotherapy, a week or 2 before, we collect your own stem cells, we freeze them, and then we give those stem cells back after the chemotherapy. So in other words, bone marrow autologous stem cell transplant or bone marrow transplant can be synonymous with saying high dose chemotherapy with autologous stem cell rescue. Again, we're rescuing your bone marrow.
Right. So what I've understood is that there's a group of people with multiple myeloma with this blood cancer of this cell that's producing too much protein that may not even need treatment, just good surveillance. But then there's those that do need, and we're given this treatment to try to knock off those cells and decrease that protein production, which is damaging the kidneys and the bone and so forth. Right. And then you may need, if you're young, then what you do is to do a transplant. So talk to our viewers about transplant. You hear about bone marrow transplant. You already said that bone marrow and stem cell transplant is interchangeable. What happens in those bone marrow transplants? I had a cousin who had a bone marrow transplant in Tampa for leukemia, which is another topic we're going to talk about today. But what happens in a bone marrow transplant? What is that?
Yeah, so there's really 2 types of bone marrow transplant. You either get your own stem cells back, which is a autologous stem cell transplant, or you get a donor stem cell transplant, which is you get a donor, somebody else's stem cells that goes into your body. I'll start with autologous stem cell transplant. Autologous stem cell transplant is for patients who have disease that primarily needs chemotherapy. This is multiple myeloma and also lymphoma. Again, this is the autologous stem cell transplant is the foundation of it is getting high doses of chemotherapy, super high doses to kill off everything. And again, as collateral damage, you are killing off your own bone marrow cells. So you rescue it with your own bone marrow cells. So it's again, I'll say it again because I think it's worth saying, high dose chemotherapy with autologous stem cell rescue. Now, the donor transplants and with regards to some lymphomas and even rare, uncommonly is myeloma, some very, very high risk myelomas, very, very high risk lymphomas, and mostly leukemias, you're going to get a donor transplant. That's an allogeneic stem cell transplant. So what happens with, there's two benefits of that. Number one, when you have a leukemia, you're creating these cells these white cells are growing at a fast rate, and your white count's high, but they're non-functional. So basically you're very high risk for infection, and eventually it'll eat up your bone marrow, and you'll eventually perish from not having a functional bone marrow. So you're going to get two benefits. You're going to get, number one, you're replacing your defunct stem cells, which are creating these leukemia cells, and you are replacing them with a healthy donor bone marrow cells, which are going to create your new immune system, which are going to create normal white cells, not ones that are going to cause problems causing leukemia. The other benefit, and this is probably the most nuanced benefit, and it's somewhat of a ingenious benefit. It's a great benefit, super scientific benefit as well. And this is another reason why I became very interested also in transplant, is you're getting something called a graft, right? The donor cells are coming in, graft versus leukemia effect, where those donor cells, they don't recognize your body as their body, right? So like, our body has our white cells going around, and they interact with our tissues, and they're like, this is my liver, this is my heart. I'm not going to attack those because that's my own body. So the donor cells, they come in, and we try to match it as much in an immune profile as much as possible. And those donor cells come in, and they will not only, again, creating a new immune system, but they are attacking the leukemia cells. So there's graft versus leukemia effect. So they come in, they grow again, and then if any leukemia cells pop up again, they'll kill those. Obviously, there's also risks. Can that new graft, the donor cells, can it actually hurt other parts of your body? Of course, that risk, which makes it a higher risk than an autologous stem cell transplant. But that's the two benefits. You're getting a new immune system, and you're also getting that graft versus leukemia effect, which obviously comes with risk.
Wow. All right. So you've mentioned leukemia a couple of times. We've touched upon multiple myeloma and what it is. Why don't we go into a little bit of leukemia and tell our viewers what is leukemia and how is it similar or different than multiple myeloma?
Yeah. So leukemia is as I said before, it's you have, again, I know I talked about these different types of these plasma cells, or these cells that create too much antibodies with regards to myeloma. Leukemia is more along the lines of, I'll use a bread and butter leukemia, is AML, right? You have these myeloid cells that they grow too much, and you can have a white count. Normal white count's like 4 to 11, give or take, and you have these white cells that go to let's say 50, and you say, oh, there's more white cells, that's great. It's actually not, because again, you have 50,000, all these white cells, but they're not functional. So it doesn't. So that puts you at very high risk for infection. That a lot of patients are leukemia patients. If treatments don't work, unfortunately, they die of infection. Not only that, but like I said with multiple myeloma, those cells will grow so much in the bone marrow, and they'll interfere with the production of your red cells and your platelets as well. So again, if there's a little bit of a connection between these two, they're bone marrow problems, right? Which is why they're both, at the end of the day, treated with bone marrow transplants. So again, leukemia, and I'll back up again too, can't really be screened for it. Can't get a colonoscopy, a blood test or something. You just, unfortunately, a lot of patients, they eventually will go to their doctor, and they get something. They see a test is a little bit off, and then they'll send them over to either the hospital or to the clinic, I'll say, oh, I need a hematologist to take a look at this.
So what I've heard here multiple times from a specialist hematologist is that going to your primary doctor and getting your primary evaluation every year, primary doctor care evaluation with your blood test is the best test to figure out if you have something that's coming and catch it early. So yeah, it's not all this complex screening or testing or CAT scans or MRIs. You know, I have patients always say, I just want a full body PET scan to see if I have any cancer growing in my body. And you and I know that that's not the way to do it. All right. So we know how to diagnose it now. You know, screening is very important. You're telling us treatment is bone marrow transplant, but do leukemia patients get chemotherapy along the way as well?
Right. And just like myeloma, which I said before, where you get treatment before, and then you can be considered for bone marrow transplant. Same thing with leukemia. You get treatment, and leukemia is treated with, chemotherapy. So that's like real chemotherapy. And again, I'm being a little bit broad because there's many different types of leukemia. But if we're talking about the ones that kind of lead towards transplant, those are the ones that need heavy duty chemotherapy. They're in the hospital, and they get, they get treated with high doses of chemotherapy in the hospital. Their counts recover, and they go through a process where they're monitored very carefully by a malignant hematologist, and eventually considered for stem cell transplant if they are candidates for that.
And so both multiple myeloma and leukemia, let's talk about cure. Since they're similar conditions, they're both in the bone marrow, as you told us. What are the cure rates for these? And I know they could vary because of the type of leukemia as well.
Yes, that's a really good question. So I'm not going to give you a pleasing answer.
Okay.
Myeloma, unfortunately, is not curable at this point. But with the caveat, it's referred to more as like a chronic disease. And I've heard this a couple of times before as different experts that I've spoken to. Multiple myeloma is somewhat akin to like diabetes. It's a chronic disease. You're going to have it lifelong. My goal is if you get diagnosed with myeloma, then you will die with myeloma and not from myeloma. So that's my goal with regards to myeloma. Of course, many patients do end up dying from myeloma. However, there's so many different drugs available right now to kind of knock it down enough. So the idea is to knock it down and keep you alive long enough. Now, the other aspect of myeloma too is that there's a really great I shouldn't say this is great, but it's interesting because there's so many new drugs that are coming out with myeloma. This year alone, there's a couple of drugs that came out, and this year alone, there's going to be more drugs next year. So a lot of times with myeloma, because it's a chronic disease, it's almost like you stay alive long enough to get the next treatment, and it's
next best one.
And quite frankly, patients ask me all the time, what do I, doc, how long I got? I can't answer that because if I give you numbers from prior studies, that patient from a prior study from 5 years ago didn't have the 4 or 5 drugs that are available today. So it's
the next 5 that's coming up in the next year.
And I don't want to, and I'll quote my, not my friend, I wish it was my friend, but Siddhartha Mukherjee, who wrote The Emperor of All Maladies. I don't know if you've ever heard of that. And he's a hematologist at Columbia. He's brilliant. And he said that in a couple years down the road, we're not going to be treating, there's some cancers we're really not going to be treating with chemotherapies anymore, drugs. We're going to be using cells. We're going to treat, these malignancies with cells. And, the myeloma and leukemia, bone marrow transplant is a sort of cellular therapy, right? The myeloma and leukemia, we're coming out with these other regimens called CARs, which are basically, we take your T cells out, part of your immune system, and we engineer them to fight lymphoma, myeloma, and then we give them back to you. Wow. So then this is like the science fiction part that I was kind of getting into before.
And that's available now?
It is available now. Yeah, it's available specifically commercially. Clinical trials available for all 3 of these. Commercially for lymphomas, it's available. There's 3 different drugs that are available for that. And for myeloma, there's 1 drug that's available. And myeloma, there's going to probably be, within the next 2 years, probably a couple more CAR T cells available for myeloma as well. So it's kind of like an unbelievable field of to be in right now in the setting of all these cellular therapies. We're moving away from these chemotherapies. We're getting into this really targeted agents that fight these tumor cells. And it's going to be and I always say this with different physicians too. I think in a couple of years, we're not going to be you're gonna get maybe in 20 years from now, you're going to get a bag of cells as opposed to a bag of chemotherapy. Yeah.
Wow. So that's incredible. It's exciting because obviously as young people we are, there's hope for us in the future. So we've talked about leukemia. We've talked about multiple myeloma, some of the bone marrow diseases. And let's finish up now in our time together and talk about lymphoma and explain to our viewers, what is lymphoma? How is it different, or how is it similar than what we've been talking about?
Yeah, so lymphoma, I don't want to get too. It's another type of blood cancer, right? We have lymph nodes throughout our body, primarily the way you can really look for lymphoma, you have these lymph nodes that are in your axilla, in your neck area, in your groin area as well. Those are probably the ones that you would most, be most well attuned with. When you're younger, you have. When you're younger, you have the cold, you can feel you feel your neck and say, oh man, like I have, if you remember when you're a kid, your lymph nodes get a little bit swollen and they appropriately do so. So you have these white cells, the immune system cells in your lymph nodes, and they get activated appropriately for viruses or bacteria. They appropriately swell because they have to fight something, and they kind of proliferate, and they have to fight something. They recruit more white cells to fight like an army, and they swell and then they go down. Lymphoma is, for lack of a better description, cells that are proliferating and they're swelling, but not in a good way. They're kind of they're swelling because some of those cells are kind of going rogue and they're growing too much. I know I'm calling it a blood cancer, right? But if you have lymphoma, you'll have a solid mass. And I have patients, sometimes they come in and the most obvious one is a neck lymphoma, and it's a big mass, and they you can see it, you can feel it. Leukemia is you can't see, you can't feel. Again, a lymphoma, you can't really screen for it, but it's a little bit more obvious. If you have a typical presentation, patient saying, I've noticed this neck mass increasing, and then they go to their primary care doctor, and then they do a biopsy and they find it's lymphoma, then they'll get sent to me. Now, lymphomas are treated with chemotherapy as well. It's pretty much like front and second line therapy are pretty standard. If you have a relapse, also a situation where you have to get evaluated for a stem cell transplant or a bone marrow transplant, and that's upon relapse. Lymphoma is probably the cornerstone in the world of malignant hematology for this cellular therapy, these CAR T cells, so to speak. So that's a blossoming field as well. So lymphoma it's great. I mean, we have chemotherapy, we have these different antibody therapies that are coming out. We have the cellular therapy, we have stem cell transplants. We have lots of different ways to treat lymphoma. And again, lymphoma is just like myeloma and leukemia, there's a lot of different types of lymphoma. So if you are ever diagnosed with lymphoma, you really need to see, a hematologist, a malignant hematologist, to kind of make sure you're getting the appropriate care.
Yeah, and I think that the important thing is to tell our viewers and explain to them, because I have patients that I'll see them from you or from a primary doctor, that we want to do a biopsy on their lymph node, and the family. I have to reiterate it so many times. I'm not going to take out that whole mass. We're just trying to get a sample of it so Dr. Nahas can treat you appropriately. And so removal of that mass is not important, right? You have to give them therapy throughout the body because the lymphoma is in all the lymph glands, right? Is that so? Yeah, explain a little bit about that.
That's a great question, because we get that question all the time, because it's easy when you're talking about multiple myeloma and leukemia. It's a blood cancer. You can't
and you don't see anything.
You don't see it. You can't do surgery for blood cancer, right? And coming from a surgeon, this is great discussion. So with regards to lymphoma, I have this mass here. Why do I have this mass here? Just take it out.
Yeah.
And not only that, but you are right. You have a mass here, but then we do a full PET scan and we do whole imaging, and we find that there are other masses throughout the body. So you can't do, I can't send you a patient and say
multiple mastectomy.
Yeah, can I do, can you cut out 10 different areas? You're gonna say, are you crazy? So but you're right, it's a blood cancer, so it's all over your body, which needs systemic therapy, meaning chemotherapy. Now, lymphomas are generally very responsive to chemotherapy. So, when you treat that, they shrink pretty nicely. And to tell you the truth, you usually get traditionally 6 cycles. Again, I'm giving you like a very bread and butter case. Traditionally 6 cycles, but after 2 cycles, I want to see that almost gone. So so if you think about it, cycles of chemotherapy every 3 weeks. So you start 3 weeks later, you get a PET scan. That's 6 weeks. In a 6 weeks time frame, I want to see that lymphoma almost totally gone. And my patients who come in and they flatten out, they have a neck mass or something, and it flattens out only
That's
in a couple
awesome.
of weeks, which is nice to see. I get a PET scan anyway, but I
Yeah,
mean,
of course.
you know, back in the day, all we had was physical exam, right? So
Wow. So we've learned about multiple myeloma, leukemia, blood cancers. Get your blood test with your primary doctors. We've learned about lymphoma and, you know, the lymph glands. If you notice something, and I always say actually, you talk about people that have written great books. The father-son combination that wrote the book on the liver, Schiff and Eugene Schiff. The father was still alive at 90 something when I was in medical school, and he always used to say, listen to your patient, they'll tell you what's wrong. And the patient comes in and they tell you they have a mass, so you know your body as a patient. You know, if you feel a lump, you know, tell your doctor and we get a biopsy of it. And so we've learned about how to diagnose lymphoma. Make sure you see a specialist, you know, that's a hematologist like Dr. Nahas. Now, lastly, it wouldn't be complete for us to spend a couple minutes to talk about COVID. And the reason I want to talk about COVID is COVID, we saw a lot of this where I saw patients with lymph glands because of vaccines or a COVID infection. And so what can you tell your viewers about COVID and lymph glands and blood conditions that, you know, just to put them at ease or to guide them in the right way?
That's also a good question. And not only that, and I obviously wouldn't know this until this year because we have all the vaccines available. But if you remember what I said, lymph nodes can be appropriately, you know, swollen, right? So, you know, what happened is that the vaccine goes in and it basically creates an immune response, right? So, and it's supposed to do that. So you can have swollen lymph nodes. And I know for a fact that's what's going on because sometimes I'm getting patients who are either on treatment for lymphoma, and they're getting they get the vaccine while they're on treatment, and that's another thing. We still you know, we still recommend.
You want the most vaccinated.
We still you still get to, you know, you still get vaccinated even when you're on treatment. But we get patients who get the vaccine while they're on treatment, and on their PET scan they show some axillary lymph nodes that pop up, and these are patients who had only neck lymph nodes or abdominal lymph nodes, and I see it pop up in the axillary. I always get my shot on my left side. That's why I'm pointing here. So I'm right-handed. So so the axillary, I see axillary lymph nodes pop up, and then the next PET scan, they're gone. And it's not because of chemotherapy, it's because the lymph nodes appropriately were swollen. They appropriately are creating what we call a memory response as well. Because, you know, you don't need the response right then and there. You need that response later on, the memory immune system, to kind of attack that COVID if it gets to that point. So if you get of a lymph node, COVID, you know, you get a COVID shot and you have a lymph node and it, you know, stays there for a while, then, you know, we have to evaluate that, you know, appropriately. I don't think I don't think you're not going to get lymphoma or some sort of cancer from the vaccine. That's absolutely not what's going on. And I have seen some patients who come in and they say, you know, I got the COVID shot and I noticed this lymph node, and, you know, we do a full workup, and, you know, one or two times you do see that a patient does end up having lymphoma, but it's not from the vaccine though. Yeah, it's a coincidence, and I cannot stress that enough. It's a complete coincidence that they ended up just presenting with lymphoma around the time when they were vaccinated. Because, I mean, this is what's happening. I mean, you know, there's an incidence of lymphoma every year, right? So if you're laying on top of that vaccine, then you're going to have some patients who are diagnosed with lymphoma and also get vaccinated at the same time.
Right, of course. All right. Well, it's been an incredible discussion. We've talked a lot about these hematological conditions, what's really not talked about a lot in our community, you know, and it's important to obviously get your checkup with your primary physician, get your blood work, know your body. Of course, get your COVID vaccines because we know that's protecting. It's protecting the sickest patients that Dr. Nahas takes care of. So you've heard about these hematological conditions. So get your vaccines, because if it's important enough for these very ill individuals, you know, it's got to be important for us as well. And so I want to thank Dr. Nahas, George, for coming to see us here today and being with us and educating our public. And once again, Dr. Anthony Gonzalez from Miami Community Health signing off. Be well out there and be safe, and see your doctors always.